I think to keep sure that we go through this topic, clearly trying to discuss recent advances in cardiology is a huge task. Having said that, I think the rampant misuse of drugs in cardiac sciences is very, very personified. And I think the off-label use in the peds population is approximately 60%, but I believe in our country it's probably even more. And most of the times the treatment decisions are based on a lot of empirical data, inadequate information, and therapeutic safety. And that's one of the reasons why it's very hard to come up with judgment calls on what is acceptable and what's not. What are the barriers for clinical trials? And this is not just cardiovascular, but generic whenever we look at pediatric dosing, is the relative rarity of disease, the disease heterogeneity, because as we've been seeing all through morning, people have been talking about the variety of disease process. There is lack of research, amount of ethical issues, and difficulty in identifying valid clinical points. So for our discussion today, it's very hard to go through the entire gamut of cardiovascular disease. Having said that, I want to stay focused on 5 key points: heart failure, systemic hypertension, arrhythmias, anticoagulation, and obviously intensive care, since I'm standing in front of you. But more importantly, what I want to do is reiterate concepts that you're using in your day-to-day practice and try and bring you up to speed in what we believe is cutting-edge research. Heart failure causes that you'll end up seeing in your units usually are related to either volume overload with preserved systolic ventricular function, and that's mainly because of large left to right shunts, admixture with high pulmonary blood flows or regurgitant lesions, or you may have myocyte dysfunction with abnormal ventricular function, and you have a host sitting at the bottom of various disease processes that can cause it. Now, the current therapy guidelines, and most of you would be practicing it in your day-to-day in your units, is either using digoxin, chronic use of diuretics, vasodilators, which include ACE inhibitors, angiotensin receptor blockers, beta blockers, and hydralazine. This is the usual pharmacopoeia that we deal with. But I think what's important for this audience is to talk about what people are now using, maybe not as often, and how this is changing the way we practice our day-to-day clinical medicine. The first one is to talk about angiotensin receptor blockers, and losartan, candestra, and valsartan are now becoming increasingly in use. Now, this is not something new. This is stuff which has been used by the adults in adult practice for a long period of time. The way they work is that they are competitive antagonists. They do not inhibit bradykinin breakdown. Very important for us, they're non-nephrotoxic. And currently, there are 2 trials which are going on, which are evaluating for hypertension in children. The beneficial effects of ARBs in heart failure, therefore, include a host of things. But I think what's very important for us, again, for the patient population that we are talking about today, is that it reduces angiotensin II-mediated vasoconstriction. It reduces and mediates the potentiation of sympathetic nervous system activity. It reduces sodium and water retention. It reduces myocardial fibrosis, and most importantly, there is inhibition of nitric oxide release. Where can we use it right now? They are primarily indicated wherever you are facing ACE inhibitors intolerance, and there is no data out there which supports the use in less than 6 years of age. Eplerenone, again, is a drug which, to my mind, is not yet FDA approved, but is again being used in a lot of trials. It's a newer specific aldosterone antagonist. It reduces sodium and water retention. It reduces the inhibition of nitric oxide. What we have seen is that there is slowed heart rate. There is an improved balance of oxygen supply and demand. There have been issues, benefits that have been described, which include reduced myocardial apoptosis and fibrosis and antiarrhythmic effects. And as is true of something which has not been put on label use yet, this will require further evaluation. Beta blockers, you would be surprised somebody talking to you about recent advances still comes back to beta blockers, because to my mind, a lot of what we practice in medicine requires reiteration and relearning whenever we come to drugs. Metoprolol and carvedilol have been drugs which are being increasingly used, at least in our units. We know that it helps in mild or moderate compensated heart failure secondary to ventricular dysfunctions, SVT and other tachyarrhythmias, and hypertension. Carvedilol would be a drug that most of you in the room, especially as pediatricians and neonatologists, would not have used that frequently. It improves systolic function, it decreases fibrotic remodeling. More importantly, it has been associated with decreased hospitalization and mortality. Now, what is the causal benefit? And the causal benefit is that these agents reduce QT dispersion, reduce the potential for sudden death from arrhythmias. And as you know, and has been discussed in the past, that whenever we are sending kids home, we are not using cardiorespiratory monitors. So I guess anything which helps potentiates benefit is something to be looked at. Carvedilol is a non-selective beta blocker. Vasodilatation it helps with vasodilatation due to alpha blockade. There is a dose reduction that is required in patients who have severe liver dysfunction. It is very, very important to titrate the digoxin dose, and you should avoid calcium channel blockers or concomitant calcium channel blockers whenever you're on this drug. So let's talk about something practical. What are the key points when you talk about the do's of management of heart failure? One is obviously treat the underlying cause. Digoxin, we know, has a narrow safety window in children and something that we need to be cognizant of. Continuous infusion of furosemide, to our mind, has always been better in acute ill cases instead of giving bolus doses. A persistent tachycardia may indicate tachycardiomyopathy as a cause of heart failure, and rapid digitalization is no longer required for the majority of cases. So something that you need to be cognizant of. What you should not be doing is combine an angiotensin converting enzyme inhibitor with angiotensin receptor blockers. Avoid combining ACE inhibitors and spironolactone. Don't give ACE inhibitors in heart failure secondary to pressure overload. Avoid using ACE inhibitors in acute decompensated heart failure. And beta blockers should not be initiated in acute decompensated stage of heart failure. Again, none of what I'm suggesting to you is rocket science, but it's very important to remember that the pairing usually does not work. These are the various drugs, and I won't waste too much time for the sake of brevity on what exists. I'm happy to share the slides and the data with you later. Now, what does the future look like when it comes to heart failure? There are strategies to optimize intracellular calcium. This is the main focus over the past 5 to 6 years on what people are looking at. Istraxime, allosteric modulators, RICALs, and then gene therapy, and I'll talk about this briefly for a second, seem to be at the fulcrum of getting into clinical practice. Having said that, istraxime which is an agent which inhibits the sodium-potassium ATPase activity. It stimulates the SERCA2 and improves relaxation. What is very important, especially in the subset of patients that we usually deal with who are sicker, is that there's no significant change in renal function, or more importantly on the neurohormones, while it improves systolic and diastolic heart function. There has been improvement in systolic blood pressures, and more, as I mentioned to you, improves the heart rate. Omecamtiv is a new agent, again still in trial. It's basically a cardiac myosin activator. It accelerates the transition rate of myosin from a weak to a strong actin, and again, going back to our physiology days, you know the interplay that takes place in the cardiac muscle. I think it improves the SET and fractional shortening with a comprehensive effect on myocardial efficiency. It's pretty well tolerated, at least in the studies that have been out so far, but as you know, anything in heart failure which decreases heart rate has a beneficial effect, at least in the ischemic cardiomyopathies. An interesting concept that is evolving and nowhere close to clinical practice is about energy substrate handling. And this comes from a basic fundamental that the healthy heart derives 70% of its energy from beta oxidation of fats. And the heart failure patient switches cardiac metabolism to fatty acids. Now, if you find ways by which you can modulate this can help both in glucose oxidation, impairs calcium handling, and LV contractility would improve. What are the evidence that is available? Again, no multi-centric. These are very small RCTs, very small subsets of population. Clearly, again, debates around whether this is something that we should be looking at, as certainly believe that this may represent a future therapeutic target. Jumping ship, moving on to systemic hypertension. Most of you sitting in this room are dealing now with the increased incidence and what you're seeing in your clinics. Clearly, what is our achievement? We are trying to achieve a diastolic blood pressure less than 85 percentile. We are trying to control hypertension with non-pharmacological means. The intention, as is true of everything that we do in peds and neonatology, is to use the smallest number of drugs, more importantly, the lowest dose that is available. But I think what's becoming increasingly common is to design treatment protocols that are consistent with patients' compliance, and in most cases, in our scenario, it's going to be the parents' compliance, and achieve long-term prevention of end organ damage. The various drugs that you see are a pharmacopoeia, but I think what's needs to become increasingly common is to come down to what we are now calling individualized treatment, where you are not just giving them a blanket therapy and sending them hoping that they'll do better, but thinking about what would be the agent which would work in your particular patient. So here's an attempt at an individualized approach. Now, using these, if monotherapy is needed, we would usually send the patients home on ACE inhibitors, a beta blocker, or a calcium channel blocker. If within 2 weeks there is no great improvement or the BP is still above the 95th percentile, we would go ahead and add to dual therapy, and the various combinations are suggested as in the slide. And then a final step, if you're still losing ground, is to add a potent vasodilator like minoxidil, which is again out of vogue, but more important, something like a central acting agent like clonidine to the pharmacopoeia. However, if the pressure continues to be 95th percentile, a third drug needs to be added, and that's what most people would end up is an ACE inhibitor with a calcium channel blocker, and then using a diuretic or a beta blocker. And as you are aware, people who have any kind of respiratory issues or are suffering from asthma or ex-BPDS, you would be a bit circumspect trying to use beta blockers with these patients. Now, if you are suffering from secondary hypertension, or that's what you're dealing with, most people will be using loop diuretics. Chronic renal failure has been defined, and obviously you'll be monitoring things like serum potassium, serum creatinine. For renovascular hypertension, which is becoming increasingly common, using a calcium channel blocker with a diuretic seems to be a good therapy module. And if ventricular function is normal or mildly deranged, as we've seen in coarctation of aortas, use beta blockers instead of calcium channel blockers. I'm horrible at remembering doses. I pretend never to do so. At my age, I've given up on this. But that's also where you can surround yourself with very smart residents and fellows who have the answers, or carry a pharmacopoeia with you. So most of my talk will not talk about giving you exact dosages. But I do want to point out over here an algorithm of plain simple hypertensive crisis. What do we need to manage? And in our country, there is always a debate around whether you should put them in the ICU, which has its adjuvant cost issues, or what is it that you can provide at home, or what you can do in the wards. And I think, again, as I pointed out, I'll be happy to share my slides with you, but this algorithm is a plain, simple, vanilla way of making sure you can take care of your patients in the hospital. Moving along to discussing arrhythmias. The Williams classification antiarrhythmic drugs has been for a long, long time. The interesting part is not too much has changed. A lot of what we were doing, whether it's sodium channel blockade, beta adrenergics, or prolonged repolarization, has been something which has been around for a long time. Amiodarone or Cordarone, as you would know, is something which has been again around for a long time. A, in adult literature for many, many years. B, increasingly now in the pediatric and neonatal literature. We use it in our units for resistance, atrioventricular resistant tachycardias, atrial flutter, atrial fibrillation, JETs or junctional ectopic tachycardias, and including VF. While the drug is reasonably well tolerated in infants and kids, hepatic and thyroid dysfunction is relatively uncommon, contrary to popular belief. Hypothyroidism and hyperthyroidism is something that you need to watch for. Again, in my experience, it's very, very rare to come across patients who get this because of Cordarone. Risk factors are depicted over above. Clearly, once you get into high dosages, which is greater than 200 milligrams a day, which is again very, very rare in our patient population, would you end up with these issues. Dose monitoring and restricting duration of therapy is the only thing you can do. But let's talk about again of some adult drugs which are now been increasingly brought into our pediatric practice. One of these is sotalol. It's a class 3 antiarrhythmic recommended for supraventricular arrhythmias. There is a modest profile in ventricular arrhythmias which is also being described. It is precluded in cases with severe left ventricular dysfunction, and that is something that I have alluded to even in the past. When you're dealing with severe LV dysfunction, you need to be careful on what you use, and can be used for fetal arrhythmias. Now, it prolongs the action potential duration. it helps in lengthening of the QTC interval. There is very limited evidence, but there is some 3 now RCTs out there which are talking about this. This can be combined with flecainide, which I'll be talking about in a minute. But what's very important when you're using sotalol is that it's contraindicated in long QTC interval patients, and that's something that you need to be constantly monitoring on your strips. Flecainide, some of you may be aware of it. Again, this is something which, while we are not getting it routinely into the country, is now available if you have the right supplier. It's a class 1C antiarrhythmic. It's inhibition of fast sodium channels. There is a prolongation again of the action potential duration. The target area of interaction here is at the His-Purkinje level and on the ventricular myocardium, and it's proarrhythmic again if ventricular dysfunction is pre-existent. What would I use flecainide in? Mainly if I want to look at acute termination of SVT, if I'm dealing with JETs, persistent junctional ectopic tachycardias, or post-op re-entrant atrial tachycardias. We have used it occasionally in VT, but not with too much success. It has successfully been used in combination with the Imiduron and sotalol, and that is the biggest benefit, because otherwise when you are dealing just with monotherapy, sometimes that's an issue. And we reduce the dosage with Imiduron. So what is, again, a practical algorithm when you're dealing with SVT in your units? Obviously, you've been trying vagal maneuvers, you tried adenosine, you've put people on esmolol, IV Imiduron, and I've talked to you about the benefits. And increasingly, when we are using something which is benign, we've been using IV diltiazem for re-entrant tachycardias in children, especially once adenosine doesn't seem to have worked. Again, this is the same algorithm, and I won't waste time talking you through it, but there is a very clear-cut picture of what you can do when you're dealing with these kind of disease processes, and where you can reach a stage where both flecainide and beta blocker or going down a calcium channel blocker seems to be the end point of what we are achieving. The key concepts that I want to leave you with when you talk about antiarrhythmics is that verapamil, avoid it in neonates, broad QRS tachycardia associations. Avoid combination with beta blockers. If you do have tachycardia with hemodynamic instability, please do not hesitate to use DC cardioversion. And this is something that I keep talking about. DC cardioversion is not bad, as long as you know when you have to use it, but please do not hesitate using it. I think in adults, people are a lot more trigger happy using this. Imiduron is best avoided for long-term usage, and flecainide is effective with normal myocardial function or minor CHDs. I do want to talk to you about, again, 2 drugs which will be coming up soon. One is dofetilide, which is a class 3 antiarrhythmic. It is now FDA approved in adults for atrial tachyarrhythmias. It prolongs the QT interval with proarrhythmic effects, and in Torsades, it has been based, and people have been using it based on current guidelines. The other drug is dronedarone. It's again similar to Imiduron, with the iodine moieties replaced by methyl sulfonamide group. This again needs to be avoided in severe LVH and in persistent and permanent atrial fibrillation. Caution is again exercised, as is true because of the fact that it can lead to hepatic dysfunction. So, where are we with antiarrhythmic therapy today? A judicious combination of device therapy, ablation, and medications is evolving as the standard. Moving into our third topic, which is antithrombotic therapy. Again, most of you have been using various forms of heparin, lower molecular weight heparin, vitamin K antagonistics, and antiplatelet drugs. Let's give you some data to prove or disprove what works, what doesn't. Clopidogrel is again an agent extensively used in adults for many, many years, not used as often in children. Having said that, we all know it selectively inhibits the ADP platelet aggregation. There was a Piccolo trial about 6 years ago which talked about how clopidogrel was well tolerated with doses of minimal 0.2 milligrams per kilogram per day with an equivalent effect of aspirin. Where do we use it today? We use it when we have cases which are intolerant to aspirin or as a combination therapy. Ticlopidine is another drug which is increasingly being used. There are now glycoprotein 2A and 3B inhibitors which are now available in the market. Again, not for label use in children yet. But in a lot of our cardiologists, especially in Kawasaki disease, have been now jumping on this bandwagon. What do we need to know about thrombolytic drugs in our units? Clearly, we've been using IV streptokinase, urokinase, and tissue plasminogen activators for a long time. What are the practical indications, especially when you have a very, very juicy central line in and you've gotten after a lot of conflict? And then you have femoral artery occlusions, you have aortic thrombosis, intracardiac thrombi, or struck valves, less effective in neonates. So I'll talk about a few specific disease conditions and what are the recommendations. If you have a blocked BT shunt, heparin is something that we use immediately. Aspirin or clopidogrel we'll give subsequently. And if you have one episode of a shunt thrombosis, then we would send patients either home on aspirin or aspirin and clopidogrel. Mechanical valves, for those of you who get those in your practice, though rarely, there are doses that we are giving for warfarin for both prosthetic mitrals and prosthetic aortic. Kawasaki disease, this is not a cardiology debate, so I'm not going to get into this, but clearly the usage of aspirin, and for big coronary aneurysms now, putting patients on clopidogrel routinely and oral anticoagulants is something that we are doing. We have been seeing now, thanks to the long-term usage of longer PICC lines and intravenous lines, that we are getting intracardiac thrombi in neonates. These are ones which is an incidental finding, or occasionally we pick that up on routine echoes. Direct infusion of the thrombolytic agent close to the thrombus, as you know, is easier said than done. What has been recommended is IV infusion of urokinase. We can be using TPA now, and that is something that we would use in our units. We titrate the fibrinogen levels above 100, and heparin infusion is always used. If I'm dealing with patients who have dilated cardiomyopathies or myocarditis, especially the ones with severe heart failure, we put them on oral anticoagulants. We keep a target INR of 2 to 3. And we spoke about idiopathic pulmonary hypertension yesterday, so I won't get into those debates, but oral anticoagulation is something that we would put our patients on. Now, if I do have arterial occlusions post any kind of procedures, as I mentioned to you, we will end up using heparin routinely. We do use IV streptokinase in our patients, and then surgery if everything else fails. What are the newer avenues that we are going to see, and over the next couple of years in fora like this will become, I think, routine, are things like, again, antithrombin 3 inhibitors. Anticoagulation is as effective as warfarin and does not require stringent monitoring, but compliance is obviously imperative. At this point of time, it's not recommended below 18 years of age, but hark back to my first point that I made to you, that off-label usage is rampant. I'm beginning to see a lot more usage now in these patient populations. So let's shift now to intensive care, which is our forte and something that I think you would be practicing a lot more commonly than probably what all the stuff that I've been talking about. Levosimendan is not a new drug, but levosimendan is also a drug which is not routinely used in our ICUs, at least in India. Now, what it does is that it causes actin-myosin cross bridges. There is no increase, and I think this is the fundamental point I want to make here. There's no increase in total myocardial energy demand and oxygen consumption. And the potential for arrhythmia when you lose levosimendan is also reduced. The stabilization effect is coming because it is calcium dependent, and the levosimendan exerts its effects both during systole, and hence ventricular relaxation is not impaired. What do we use it for? It helps in providing adequate ventricular filling, and optimal coronary perfusion is then ensured. What is the current evidence? It has been proven more in Europe, less in the US, that it's beneficial in neonates due to immature calcium responsive myocardium. It's beneficial as a bridge therapy. No significant edge, and this is our belief, over milrinone in recent trials, and there are now almost 20 to 22 trials available to document this. It is beneficial in patients on beta blockade, and in severe low cardiac output syndromes, it helps cut down on high catecholamine use. Where would you not use levosimendan is severe renal or hepatic impairment, severe ventricular inflow or outflow obstructions, severe hypotension, and history of torsades. Nizirotide is a drug that some of you may have started to hear of. It's a human recombinant BNP. It's currently recommended in adults with congestive heart failure. There have been, again, sporadic trials in children, where it has shown to improve diuresis. It reduces filling pressures and vasodilatation. There is improvement in cardiac output, decline in endothelium levels, and more importantly, we believe that this is something which is now definitely in the pediatric literature. Clearly, not enough work has been done in the neonatal literature to recommend usage today. I'm deliberately bringing in thyroid hormone because this has been around for 25 years, debates around whether you should be supplementing thyroid hormones or not. For my perspective, when I'm talking about cardiovascular disease, we do know that cardiopulmonary bypass and critical illness suppress thyroid hormone levels. We do know that T3 levels positively influence the ventricular function. We do know that this modulates immediate effects. We do know that it can improve intracellular calcium. So whether this is of beneficial or not, the jury has been out for 25 years. I do know it doesn't do any harm within a narrow therapeutic range. Do I routinely recommend it to our patients? The answer is no. But if somebody does ask you if it can be of benefit, the answer is yes. So let me take a few minutes to give you some practical tips, or at least what we believe is our inotrope strategy in the units that we work in. If you're dealing with patients with RV diastolic dysfunction, our first drug is after fluid is dobutamine. So till you have not filled up the ventricle, do not go to an inotrope. Fill up the ventricle. How much fluid? I don't know the answer. I would certainly give 10 to 20 mils per kilo of aliquots. Once I've got adequate filling pressures and I see a benefit in the blood pressure, only then will I add an inotrope. We tend to use dobutamine and epinephrine as our mainstays when it comes to RV failure. We tend to use digoxin for rate control. If we are dealing with diastolic dysfunction, our drug of choice is milrinone. We avoid catecholamines generally in the presence of a dynamic gradient, especially if it's across the RVOT. If we are dealing with severe LV dysfunction, dobutamine and or a combo of milrinone is something that we use. As you know, milrinone is a very good ventricular afterload reducer, so it is very helpful to put that on. Most of the times, I think the combination strategy of dobutamine and milrinone works very well. If the filling pressures are high of the chambers, using NTG or SNP. So again, practically we end up starting with SNP in the beginning, but then as you have seen, SNP is something which is harder to titrate. Also, SNP has its own known adverse toxicities. So we switch over to NTG relatively soon. Very rarely, if epinephrine is added, if we are having problems in weaning off, or we feel that the kick that is needed for the ventricle may be required. Now, kids in congenital heart disease come in various complexities. So clearly when you're dealing with unique ventricular physiologies where you have systolic dysfunction, which is combined by the nemesis of parallel circulation, where we see aortopulmonary shunts. The hazards that we have always seen is that there is pulmonary overcirculation, so the lungs are full, pulling them off the ventilators is very, very hard. The aim here is to reduce the systemic vascular resistance, and that's where I think a combination of milrinone, dobutamine, and low-dose epinephrine works reasonably well. Cardiogenic shock in a newborn, pulmonary hypertension, whether they tell you this on data or they show it to you on echo, this is invariably associated and something which needs to be looked at. Dobutamine with a low dose dopamine, again I want to point out, I am a complete non-believer in renal dose dopamine. There's nothing like that that exists anywhere in the literature, anywhere in the world. In spite of that, people tend to use it a lot. Less than 5 max of dopamine, you're wasting your time. End up using some amount of dopamine. There's nothing called renal dose. But with epinephrine added on, if shock permits, I have already told you my bias towards using milrinone. That's something which will keep showing up on my slides. Clearly, you will have to work at the basics of making sure that metabolic parameters, which play a huge effort and in fact impinge upon your ability to use drugs by not treating hypoglycemia or not monitoring simple things like ionized calcium, go a long way in hindering what you do with your patients. And use vasopressors judiciously if catecholamine resistant shock. We tend to use central lines very, very commonly. I think the bias towards not using a central line, even in units which may not have adequate monitoring, should now be dispensed with. It's very hard to titrate these kind of drugs with peripheral IVs. When you're dealing with vasoplegic shock, this is essentially either due to prolonged cardiopulmonary bypass or sepsis. Dopamine, dobutamine with epinephrine, norepinephrine or vasopressin now is increasingly in the vogue. Vasopressin, as you know, is now part of the whole ACS list and the PALS that we are putting in, and now glucocorticoids are people are using it increasingly when it comes to severe shock. Do I routinely recommend using steroids for patients like this? The answer is no. But clearly, when we've been looking at least adult literature that has been coming out, high doses of glucocorticoids is something that is working when you're dealing with the patients. Again, we believe that it warrants a balance of inotropy and vasodilatation. Dobutamine-milrinone combo is something that we look at. It's essential to balance the mean arterial pressures in a desirable range. When using more than a single vasodilate, it's important to make sure that you don't overlap meds. And calcium and magnesium homeostasis needs to be guarded. And MAG is something we tend to routinely overlook in our day-to-day practice, but I can tell you it's something that should be used and done judiciously. Sildenafil was talked about yesterday. In our units, we tend to use sildenafil reasonably routine. We have not graduated to using nebulized sildenafil yet, and that's only because of the paucity of data, and we've not been able to prove or disprove any beneficial effects. So at this point of time, we are still on IV sildenafil and then graduate onto PO sildenafil. We've talked about this yesterday on how it is evolving. Clearly, most of our kids with persistent pulmonary hypertension will end up with sildenafil. Bosentan is something that we are using, again, very routinely in our ICU. We initiate it at 1 to 2 milligrams per kilo, then increase it to 2 to 4 milligrams per kilo. It's extremely important in these patients to evaluate the LFTs. Why we have been using this is that we believe that it actually has been helping in entities which require ETB, receptor-induced vasodilatation, and to our minds actually our results, and this is something that we are in the midst of a small trial which we hope to bring out later on this year, which will talk to you a bit more about the data that we've published. Now, there is an organization called the Pediatric Cardiac Society of India. Most of the data that I shared with you today has been randomized controlled trials within the agency here. Unfortunately, I don't think there has been too much interaction between groups such as the Neonatology Forum and the PCSI, but clearly through organizations like this, we hope to bridge this gap where we do come up with consensus statements which can be used both in the neonatology and pediatric practice. Keeping time in mind, clearly if I were to conclude, my firm belief is that in the US you have things like the Pediatric Exclusivity Provision and the Best Pharmaceuticals Act, which has gone a long way to stimulate pediatric research. Our country requires similar such pushes to ensure that we don't just copy paste what is presented abroad and brought in, because the dynamics and the way we practice medicine, there are nuances to it. Having said that, as was brought out earlier this morning, it requires a lot more collaborative research where we share data with each other freely. I also believe that there needs to be fundamental changes in the way pediatric research is supported and the approval process, which at times can be extremely excruciating, especially for those of you who've made the attempts to try and do a trial. And the goal of effective and safe therapy can never be compromised, and that is something that when we're dealing with neonates and peds, something that we would not look at. This is my last slide. I hope it's not true, but if it were, the entire blame is mine. Thank you very much for your attention.